Hello, my name is Tasha Duncan, and I'm the National Director of Field Development for MGFA. Today, it's my pleasure to introduce to you Dr. Rudrani Banik. Dr. Banik is an Associate Professor of Ophthalmology at the Icahn School of Medicine at Mount Sinai. She's also a member of the Ophthalmology Faculty Practice at New York Eye and Ear Infirmary of Mount Sinai. She is a board-certified ophthalmologist specializing in neuro-ophthalmology and comprehensive ophthalmology. Today, Dr. Banik will be speaking to us about optical myasthenia gravis. Please welcome Dr. Banik.
Hello, my name is Dr. Rudrani Banik, and today I'm going to be talking about ocular myasthenia gravis. And I want to first thank the Myasthenia Gravis Foundation of America for inviting me to speak at this conference. I actually had given a talk back in 2019 on the same topic during the live conference in Atlanta. It really is a pleasure to be back here and share some of this important information. So let's get started here. So ocular myasthenia, as we sometimes lovingly call OMG, can cause quite a few disconcerting symptoms and signs. So we will go through that during my talk, and I'll also be talking about what are some possible treatment modalities for ocular myasthenia gravis. However, before we get to those specific topics related to ocular myasthenia gravis, I would first like to cover just some basic information about myasthenia gravis, some of which you may already know, but I do think it is important to review prior to talking about the specific ocular manifestations of the disease. So as most of you already know, ocular myasthenia gravis or myasthenia gravis is an autoimmune disease in which the immune system becomes activated. The body creates antibodies against itself, and these antibodies are called autoantibodies. Now, the autoantibodies in myasthenia gravis are targeted specifically against skeletal muscle groups, better known as voluntary muscles. And these antibodies block the receptors on the muscle and leading to loss of function of the muscle. So the muscle cannot contract normally, and the ultimate result is weakness of the muscle. This schematic shows you what a normal neuromuscular junction looks like. The neuromuscular junction is the connection between the nerve and the muscle. So here in yellow, you see this is the nerve, or also called the neuron, and the chemical released by the neuron when it's stimulated is acetylcholine. This chemical is released by the nerve into a space between the nerve and the muscle. The muscle here is depicted in pink. And so the muscle has these hills and valleys within it. And on the surface of the muscle are receptors known as acetylcholine receptors. And so these receptors are available to bind to the acetylcholine, and then that binding leads to chemical reactions that ultimately result in muscle contraction. So this is what a healthy neuromuscular junction would look like. What happens in myasthenia gravis is that antibodies, shown here in green, are created by the body, and they bind to the neuromuscular junction, the receptors on the muscle. And what ultimately ends up happening is that the acetylcholine that may be released by the nerve ending is not able to bind to the receptor, and the ultimate effect is weakness of the muscle because there's reduced transmission of that signal. So a lot of my patients ask me, what is myasthenia gravis? Why do I have this problem? What's going on? What is the root cause of myasthenia gravis? Well, as I mentioned earlier, it is an autoimmune response in which the body creates autoantibodies and stimulates inflammation. The inflammation ultimately leads to destruction of the nerve and muscle. And so here, again, this is a different schematic. You can see the nerve leading to the muscle. Here's a muscle cell. And this again here is a healthy neuromuscular junction. And here, not only are there antibodies against the acetylcholine receptor, but also with chronic inflammation stimulated by these antibodies, the end terminal of the muscle has been destroyed. So it no longer has those nice hills and valleys. That neuromuscular junction has been flattened. And this is a chronic change that happens, again, from chronic inflammation because these antibodies ultimately stimulate an immune response as well. So going back to the question, what causes myasthenia gravis? Again, it is in terms of when we think about the root cause, there's not just one root cause, there are multiple ones. So let me just go through what some of them may be. And again, this is all an introduction to myasthenia, and then we'll talk about ocular manifestations in just a few minutes. So in some people, they may have a genetic predisposition to myasthenia gravis. However, that genetic predisposition in most individuals is not the only factor that leads to the manifestations of myasthenia gravis or the immune response. There usually is a second factor or risk that happens that superimposes on top of the genetic predisposition. So one possibility is that there may be an infection that triggers the body's immune system to create autoantibodies. Now, I should just say also the infection may be either a bacterial infection or a viral infection. Another possible root cause of myasthenia is a vaccine. And sometimes vaccines, they are intended to trigger an immune response, so the body reacts and creates a protective immune response. But sometimes the immune response may cross-react with the receptors on the neuromuscular junction. So it stimulates an autoimmune response. Other risk factors or potential root causes include medications. Now, this is a very large category, and it really should, when you're thinking about medications that may prime someone towards developing myasthenia, it really should be taken individually because everyone is different. But I will say that there are certain classes of antibiotics, for example, some of the fluoroquinolone antibiotics, or even some of the statins that are oftentimes used for cholesterol lowering effects, can sometimes in some patients trigger myasthenia or a myasthenia-like syndrome. Moving on, there are also cases of congenital myasthenia in which the antibodies are in the mother, but they get transmitted through the placenta to the fetus. And when the baby is born, there may be a transient myasthenia syndrome. And then I'd also like to really stress here the importance of stress. So many of my patients have reported that they have their flare, their initial onset of myasthenia or flare-ups of myasthenia when they are under periods of stress, whether that be physical stress, mental stress, emotional stress, that can certainly affect your body's immune response and perhaps even prime someone to developing symptoms of myasthenia gravis. And then finally, I'm just going to add here toxins. Now, this is still an area that's under investigation, but there is a potential role for toxin exposure and the development of myasthenia gravis. And finally, there's this category of idiopathic, in which case we don't really know what the cause is or what the possible causes are for myasthenia gravis. So when we think about myasthenia, even though you've probably heard that it's divided into two categories, generalized myasthenia gravis or GMG and ocular myasthenia gravis or OMG, they are both in fact caused by the same processes. And it really is a matter of which muscles are primarily affected. And we do know that in many cases of myasthenia, usually the ocular muscles are affected first. And in up to 50% of patients, they may initially present with ocular symptoms before they develop generalized muscle weakness, generalized symptoms of myasthenia. So it really is important to watch out for some of these symptoms, to be aware of what they are. That way, that will help you seek medical care sooner, or perhaps get someone you love who may be suffering from some of these symptoms, the proper diagnosis and treatment in a more efficient manner. So let's talk a little bit about the muscles that are affected in each of these clinical syndromes, which again are really the same process, just affecting different muscles. So in general, myasthenia gravis, as I mentioned earlier, myasthenia affects skeletal muscles or voluntary muscles. The large muscle groups can be affected of the arm, of the legs, particularly the proximal thigh. Sometimes the respiratory muscles may be affected as well, the muscles that help us breathe in and out. And also occasionally some muscles of digestion can be affected as well. So chewing, swallowing can be affected as well with generalized myasthenia. In ocular myasthenia, usually it starts out with the muscles around the eyes, either the muscles behind the eyes in the eye socket or the muscles around the eyes that help us open the eyes and close the eyes. Sometimes other muscle groups in the face may be involved as well with ocular myasthenia, and sometimes we still categorize it as ocular myasthenia, even though there are additional muscles that are not purely the orbital muscles that are affected. So there are many muscles in the face. There are probably at least 43 muscles in the face that help us control facial movement, and many of these muscles can be affected with myasthenia gravis as well. So when we talk about ocular myasthenia gravis, in terms of the eyelid, there are really some important muscles to point out here. So first would be the frontalis muscle here. This is the muscle that lifts the brow up. So sometimes that can be affected, causing drooping of the brow. But also, this muscle is also very important. This is the orbicularis oculi muscle. And this is a circular muscle that goes around the eye socket. And when it contracts, it helps you actually close the eye. So that muscle can be weakened, whereby somebody may not be able to close the eye. And then here, this little muscle right here is also very frequently affected in ocular myasthenia gravis. This is the levator palpebrae superioris. I know it's a mouthful to say, but this is a muscle within the eyelid that helps us to open the eyelid. And oftentimes that muscle is affected, leading to droopy eyelids and weakness of the entire eyelid. Also, there are muscles in the eye socket that I had mentioned earlier. So we have 6 muscles behind each eye that helps control our eye movements. They help us move our eyes up, down, right, left. And there are also, those are 4 muscles that do those functions. And then there are also muscles that help us control rotation of our eye as well. And so there are 6 muscles behind each eye. In myasthenia gravis or ocular myasthenia gravis, typically it is the 4 muscles that control vertical and horizontal movement that are involved by myasthenia. The rotational muscles, called the oblique muscles, tend not to be affected with myasthenia gravis. That's not to say that they cannot be affected, but in the majority of cases, they are not affected. And these are the muscles you see here. So usually most people, we don't see these muscles. They are behind the eye socket. They're behind the white part of the eye, which is the sclera. But here you have the medial rectus, the lateral rectus, the superior rectus, the inferior rectus, that are the 4 primary muscles that are involved with myasthenia gravis. This is a view of the eye, a side view of the eye where you can see the muscles. And these muscles connect back to the back of the eye socket. Okay, so again, I do want to just pause here to say that to just emphasize that a myasthenia is an autoimmune disease, and oftentimes autoimmune diseases go hand in hand. And so sometimes the symptoms or even the ocular symptoms of the disease may extend beyond myasthenia if there are other autoimmune diseases that are coexistent. So I'm going to briefly just describe what some of these conditions are, and then we'll get back to talking about the specific ocular manifestations of myasthenia. So because autoimmune diseases go hand in hand, we always have to think about a particular autoimmune disease called thyroid autoimmune disease, because it can affect the eyes as well. And thyroid autoimmune disease encompasses both Graves' disease as well as Hashimoto's thyroiditis. And patients with either Graves' or Hashimoto's can have ocular features as well: protrusion of the eyes, bulging, double vision, swelling, etc., sometimes even vision loss and high eye pressure. So it is important to consider that when we're evaluating a patient for ocular myasthenia gravis. This is what a classic patient with autoimmune thyroid eye disease may look like. Here you have an eye that is really congested, it's bulging, you have some lid changes where rather than the eye being lower than it normally is in myasthenia, the eye is actually higher, something called lid retraction, a lot of congestion and protrusion again as well. Lupus can also be associated with myasthenia gravis, in which case we look for on the face a typical facial rash that we see with lupus, and there are some other ocular manifestations as well that can occur with lupus. Rheumatoid arthritis, even though typically it affects joints, it can also affect the eye. It can cause inflammation on the surface of the eye, in the cornea, on the sclera. Sometimes it can even cause inflammation inside the eye, something we call uveitis. So it's important to look for that. And diabetes type 1 is also an autoimmune disease that can cause many adverse effects in the eye as well that we always look out for. And finally, inflammatory bowel disease. Actually, not finally, I have one more before I get to the next section, but inflammatory bowel disease, whether it be Crohn's disease or ulcerative colitis, can also be associated with ocular symptoms, primarily inflammation in the eye. And then finally, 2 other autoimmune diseases, vitiligo and alopecia, even though, again, they primarily affect the skin or with hypopigmented patches, or they affect the scalp with hair loss can also affect the eyes and eyelids as well. So coming back to ocular myasthenia gravis, what are the symptoms of ocular myasthenia gravis? Well, the most common symptom is ptosis. So P-T-O-S-I-S. We pronounce it ptosis, like T-O-E-S-I-S. And here you see there's this woman. She has a droopy eyelid on. This is actually the right side because we're looking at her. So everything is reversed when we're looking at her. But this is the right eyelid, and it's lower than it should be. And perhaps the left eyelid is just a little bit lower than it should be as well. So this is ptosis, primarily in the right eye, but a little bit in the left eye. But it's an asymmetric presentation of ptosis. Here we have a patient who has bilateral ptosis. So you can see that this individual's eyelids are significantly droopy, and they're actually so far down that they're blocking the individual's pupils. So this person really has a very difficult time seeing because their lid is literally blocking their vision. This is again more symmetric. Here you have some advanced ptosis where the patient really cannot lift up his eyes to see. So he's actually using his brow muscles and his frontalis, that muscle I was explaining about before. He's using those muscles he's recruiting those muscles to try to lift up his eyelids, basically like a pulley system. And then this patient has a very similar appearance using her muscles, but also she's adopted what we call a chin up position because she really cannot see if she keeps her head straight. So she has to adopt this type of position to be able to clear her pupils so she can see through the bottom part of her pupils with this chin up position. Okay, so a few features of ptosis that you should be aware of. Ptosis, when associated with myasthenia gravis, does tend to fluctuate. So we call this a diurnal variation, where typically in the morning when someone is very well rested, the ptosis is not that severe. As the day goes on, things can worsen significantly. So this is an example of an individual who in the morning has relatively good lid function and lid position, but as the day goes on, his lids start to droop. And many people oftentimes report this as, they're fine in the mornings, in the afternoons, they start to have a little bit of fatigue. By the evenings, they're really, really tired out, and they just can no longer function in terms of keeping their eyelids open. So it can be very, very debilitating to have this degree of ptosis. Now, another feature of ocular myasthenia gravis is that some of the features improve with cold temperatures. So we oftentimes use a test called an ice test. And this test is basically applying a cold pack of ice to the eyelid to see if there is improvement. And why does the ice work? Well, we're not 100% sure. The theory is that the cold temperature allows acetylcholine to remain at the neuromuscular junction. It does not get degraded as much. And so there's more signaling within the neuromuscular junction. So here, this is an example. You see an individual who has significant ptosis of his left eyelid. And then he applies some ice, and he's applied an ice pack. And usually the ice pack has to go directly on the muscle that's involved. So direct ice. And we usually keep it for 2 minutes, and then we reevaluate. And so you can see that after 2 minutes of ice, his eyelid opens up very nicely. Now, unfortunately, this effect is very transient. In some patients, it only lasts a few seconds, up to a few minutes, but it's not an effective therapy that you can use throughout the day just because it's not very practical to keep putting ice on your eyelids. But the ice test is very useful for clinicians as a diagnostic test for myasthenia gravis. We actually use it in the office as a diagnostic test. Of course, we always follow it up with additional testing, but sometimes it is the first and easiest thing that we can do if we're suspicious about myasthenia gravis. Now, I also want to just mention a few things about myasthenia and ptosis in children. So definitely children can also develop myasthenia gravis, so pediatric myasthenia. In some cases, the ptosis may be very mild, as we see in this young child. She has a little bit of ptosis, very imperceptible amount of ptosis on the right side, and the left lid looks like it's normal. So maybe there's only 1 to 2 millimeters of ptosis here, and this is not affecting her vision. However, if you have a child, or if we're dealing with a child who has significant ptosis, for example, this child is such severe ptosis that his eyelid is completely blocking his pupil, he's not able to see. And so if this continues chronically, the concern is that the vision in that eye under the droopy lid will not develop properly and can lead to a type of vision loss known as lazy eye or amblyopia in medical terms. And this really does need to be addressed and corrected as soon as possible, because if this is not corrected early, so in children before age 10, this amblyopia or decreased vision may set in and may never be able to be corrected in the future. So it really is important to diagnose and treat these young children very, very aggressively, so they can develop equal vision in both eyes, so they are not at risk for developing lazy eye or amblyopia. Now, another common feature of ocular myasthenia gravis is double vision, known as diplopia. And in this condition or this manifestation, the eyes are not aligned. And when the eyes are not aligned, it's a condition known as strabismus. And the misalignment in myasthenia can be in multiple different ways. There may be a vertical misalignment where one eye is higher than the other eye, or perhaps there's a lower vertical misalignment where one eye is lower than the other eye. There may be also horizontal misalignment when one eye or both eyes may be crossed in, or conversely drifting out, or one eye or both eyes drift out horizontally. Sometimes there's a combination of horizontal and vertical misalignment, in which case there's a diagonal or oblique misalignment, and the patient sees their images displaced kind of at an angle or diagonally. Now, the other types of strabismus may cause either vertical double vision, up and down double vision, or horizontal double vision, where one sees two images side by side. As I mentioned earlier, if there's a horizontal displacement, the eyes may be crossed in which case it's called esotropia, esotropia. Again, it could be one eye, maybe both eyes that are crossed in due to myasthenia. Also, there may be exotropia, where the eyes drift outwards. So you can see in this individual, one of his eyes is drifting out, the other eye looks like it's looking straight, but there are also cases where both eyes are drifting out. And you can imagine that's very, very debilitating to the patient. To see two separate images. One eye is seeing this lateral aspect of their peripheral vision, and the other eye is seeing the other aspect. So it's very, very difficult for them to navigate, to do normal tasks like reading, driving, etc. And there's also obviously a safety concern when people are seeing double in that fashion. In terms of the vertical misalignment, so in this individual, her one eye is upward, so this is a hypertropia because the eye is higher than the other. In this young child, also this eye is higher than the other, so hypertropia. And then there may be also cases of hypotropia when one eye is lower. Now, whenever someone first presents with ocular myasthenia gravis, we always ask them about some systemic symptoms, because perhaps they are having some symptoms, but they just are not aware of them, or perhaps they didn't think much of them. So the typical questions I ask include, do you have any difficulty breathing? For example, do you get short of breath? Do you have any difficulty swallowing or chewing? Does food get stuck in your throat? Is it difficult to swallow solids? I also ask them about their voice, because in many cases of myasthenia gravis, their laryngeal muscles will become weak and their voice may become hoarse or raspy. So it's an important question to ask. I also ask about neck weakness, because sometimes patients will have their neck extensor muscles or flexor muscles become weak, so their neck is just not strong enough to support their head, and their head falls down this way. And so I always ask about neck weakness and also weakness of the shoulders. Can they raise their arms up? Can they lift their arms above their head? Can they comb their hair? These are some typical questions that I ask my ocular myasthenics, just to see if they may potentially have some subtle symptoms of generalized myasthenia gravis. Okay, so let's now talk about how is ocular myasthenia gravis diagnosed. As I mentioned earlier, we can certainly use the ice pack test in the office. Oftentimes we combine the ice pack test with the rest test. So what the rest test is simply closing your eyes and resting your eyelids for 2 minutes and then opening. And we look for we first record the baseline lid position, and then we have the patient rest for 2 minutes, and then we record the post-rest position. And any improvement of 2 millimeters or greater is considered a positive test. And the same holds true for the ice test. We have the patient hold ice on either one eye or both eyes, depending on which eye is involved. Any improvement of 2 millimeters or more is considered a positive test. Those are both the rest test, ICE tests are quite sensitive at picking up myasthenia, but I also always like to follow those up with an actual antibody blood test. So I typically get acetylcholine receptor antibodies binding, blocking, and modulating. The MuSK test, a muscle-specific kinase antibody test, I have not found to be of high yield in ocular myasthenia gravis, so therefore I don't order it often unless they have systemic symptoms as well. So it's the 3 acetylcholine receptor antibodies that I tend to stick with. And then there can also be pharmacologic testing done to diagnose myasthenia. So there's a drug called Tensilon that can be used. It's not readily available in the US currently, but it has been used in many cases to diagnose generalized or ocular myasthenia gravis. Also, prostigmine can be given, which is neostigmine, and it's given intramuscularly, and that can be done in the clinic or office as well to diagnose ocular myasthenia gravis. Usually the injection is given into a large muscle group, either the arm or the leg or the buttocks, and we wait about 30 to 45 minutes, and then we can reassess the patient in terms of their eyelid position and their double vision to see if there's any improvement. The gold standard for diagnosing ocular myasthenia gravis is the single fiber EMG test, SFEMG. So I found that in many of my patients who have regular EMGs or even simply a repetitive nerve stimulation test, that may not be sufficient enough to pick up ocular myasthenia. So I usually specify that I want to get a single fiber EMG when I refer the patient to a neuromuscular specialist. And of course, if someone has any of these diagnostic tests that are positive for ocular myasthenia gravis, we absolutely must do chest imaging to rule out a thymoma, the benign tumor of the thymus gland. And we can either do a CAT scan or MRI. I always prefer to do MRIs in younger individuals to lower the risk of radiation, if side effects in the future. And I typically do get the scan with contrast. So moving on, I want to talk a little bit for a few minutes about treatment of ocular myasthenia. So the treatment is really aimed at improving symptoms. So it really depends on what the patient's symptoms are. If they're having double vision from strabismus or misalignment, or if they're having droopy eyelids or both. So let's talk about the general approach to treatment. We always first try medical therapy, always. And whether that's medications or medications plus additional types of medical devices, whether it be prism glasses or glasses that have a lid crutch attached to them. And we'll talk a little bit more about the medications. Surgery, I tend to reserve for cases that are refractory, meaning that they're not responding to medical treatment, and only after some time. So it's not that, someone hasn't responded within 2 or 3 months, so immediately they're going to go for surgery. No, we usually wait at least 1 year, sometimes 2 or 3 years before recommending surgery for myasthenic type ocular symptoms, because sometimes patients do have spontaneous improvement, and we definitely do not want to operate too early and then cause them problems down the line. So in terms of surgery for double vision, we can do strabismus surgery to realign the eyes, and for the eyelids, we can do eyelid surgery to lift up the lids. So let's talk about medical therapy. Pyridostigmine bromide or Mestinon is usually first-line therapy. It's a cholinesterase inhibitor, so it allows more acetylcholine to remain at the neuromuscular junction. This is typically dosed at 60 milligrams to start out with 3 times a day. And I always give it with food because sometimes a side effect may be cramping in the stomach or loose stools. So I don't want patients to be suffering from that. So I always tell them, make sure you eat first before you take your medication. And the medication, the dose can be titrated upwards as needed and tolerated. The lowest dose that I've used is 30 milligrams once or twice a day for people who really can't tolerate the higher dose. And there is also an extended release formulation that can be used. So again, what does Mestinon do? It basically allows the acetylcholine that's been released into the neuromuscular junction area to remain. So it potentiates the acetylcholine that's been released, thereby hoping that some of this acetylcholine will somehow get to the muscle receptor and be able to be effective for the muscle contraction. The unfortunate thing about Mestinon is that it is transient. It only lasts about 4 to 6 hours, and therefore it needs to be dosed multiple times a day. I mentioned that I initially start out with 3 times a day dosing, but there are some patients in whom we need to go up to 4 times a day, even up to 6 times a day, depending on how severe their symptoms are. And of course, the side effects I mentioned earlier. Another common side effect is twitching of fine muscles. So sometimes patients will report, I took my Mestinon and now I have this little twitching, these fine muscle spasms in my hands or my face or my tongue. And I tell them that's a side effect of Mestinon, and that does happen in some individuals. Another way to treat myasthenia gravis is to treat the immune response, to treat the autoimmune underlying response. And so, sorry, let me just move on to here. So right now, the first line of treatment tends to be steroids, oral steroids. If it's severe, then we can consider giving intravenous steroids called Solumedrol, or Decadron, or is another name for the IV form. And then, of course, steroids can have multiple side effects. If someone is on steroids for a long period of time and they're not tolerating it well and they still require steroids, or if they're simply not able to be on steroids, if they have diabetes that's not well controlled, then they may not be a candidate for steroids. Then oftentimes we will switch them to a steroid-sparing agent. These are some of the agents I've used very frequently in ocular myasthenia gravis with good results. So azathioprine, also known as Imuran, mycophenolate mofetil or Celcept, cyclophosphamide, Cytoxan, and in some cases methotrexate if they cannot tolerate any of those other medications. Also, there are some other treatment options as well. Plasma exchange or plasmapheresis can be done, or intravenous immunoglobulin, IVIG, can be given monthly for maintenance therapy of myasthenia gravis or ocular myasthenia gravis. Now, there are some biologic agents, which I'm sure you'll be hearing about during this conference, that are approved for systemic myasthenia or generalized myasthenia. And if the patient has a combination of ocular and generalized, they may be a candidate for one of these treatments. So eculizumab, which is Soliris, rituximab, Rituxan, and then there's some other newer therapies in clinical trials, and I believe one other therapy that was recently FDA approved as well. But that is really beyond the scope of my talk. What about thymectomy? So we know that thymectomy can be very useful in generalized myasthenia gravis. There was a trial that was published in the New England Journal of Medicine several years back that showed the benefits of thymectomy. Can we or should we use thymectomy for ocular myasthenia gravis? Well, we don't yet know. There was a clinical trial that was planned. I'm not sure exactly how far along it is in terms of funding, in terms of it actually beginning to recruit patients. But we were planning, at least a group of neuro-ophthalmologists and neuromuscular specialists were planning this trial to look at thymectomy for ocular myasthenia gravis and its potential benefits. Certainly, if someone has a thymus gland tumor, a thymoma on their scan, then yes, we would absolutely recommend a thymectomy. However, if they do not have an actual tumor, the question is still unclear as to whether they would benefit from a thymectomy. And then in terms of other ways to manage some of the symptoms of ocular myasthenia gravis, for ptosis, there is a possibility of using eyelid crutches. Now, unfortunately, there are not many opticians who still make these glasses because there's a small kind of a wire that needs to be fitted and welded to the glasses frame. So you can see here that on the inside of the glasses, there are two little wires that are curved. And what these wires do is that they mechanically go underneath the top of the eyelid and they lift up the eyelid. So here you can see, here's an individual who has ptosis and he's fitted himself with the lid crutch glasses and it goes into the crease of the eyelid. And here with the eyelid crutch glasses, he can actually see quite well because his lid is nice and open at this point. However, there is a caveat when using these eyelid crutches. The caveat is that because the eyelid is open, one would not be able to blink properly. And so that may potentially increase the risk for dry eye, and in the worst case scenario, even a corneal ulcer. So we need to recommend these eyelid crutches very carefully, make sure the patient understands their limitations, and make sure the patient is lubricating if they're using eyelid crutches. Then finally, surgery may be an option. Again, it's not first-line therapy, but certainly if the patient's not responding to other treatments or if they're not tolerating other treatments, surgery may be appropriate. So this is a very nice example of, I think I'd shown you this young woman before. She had significant ptosis in one eye. She actually just had surgery on one eyelid and it lifted it up, and she looks very, very symmetric in her postoperative photo here. And there are a couple of different types of surgery that may be performed. So definitely if you are a candidate for surgery, talk to your oculoplastic specialist about which surgery is best suited for you. There may be something called a levator advancement that may be appropriate, or a Frontalis sling. And in a sling, basically, there is usually it's a silicone band that's kind of weaved under the eyebrow and into the eyelid. So basically that allows an individual to use their eyebrow to lift up their lid. So it's basically, again, like a pulley system whereby lifting up the brow and the muscle here in the forehead can lift the lid up as well. So here we have a few patients who've had ptosis surgery with Frontalis slings, and you can see the benefit here. This patient really was having a very hard time seeing. Her eyelids were basically at half mast, and then after her Frontalis sling surgery, she improved significantly. And the same with this patient as well, with a really good functional result. Now, in terms of the double vision, prisms can be used. Now, prisms are optical devices that we use to measure the amount of double vision. So we can measure how much vertical or horizontal or oblique double vision one has. With prisms, we neutralize that double vision with prisms, but prisms can also be applied on glasses. So here you see this is a prism bar, and the prisms are of increasing strength. And we basically neutralize the misalignment with the prism, and then we know how much prism to put into the glasses. And initially, I always like to do a temporary prism first, called a Fresnel Prism. Some people call it a Fresnel Prism, but a Fresnel Prism. And this prism basically has very fine lines. It's clear, however, it has these very fine lines that realign the image optically onto the retina in the back of the eye to get rid of the double vision. So it basically creates a crutch. It doesn't really solve the issue of the misaligned eyes, but it realigns the optical image so that the individual does not see double. Now, prisms must be fitted by preferably a neuro-ophthalmologist in myasthenia, or even an optometrist can do it, as long as the measurements are stable. Now, if you remember back, this is quite a few years ago, former Secretary of State Hillary Clinton had a fall, and she ended up wearing some prisms. So you can see here, this is what a fit prism would look like. So it would go onto glasses, and you can still see a little bit of those lines of the prism, but it is overall clear. The lines do unfortunately degrade acuity a little bit, so it can result in 1 to 2 lines of decreased vision when one is wearing a prism for their double vision. And this is, again, a more close-up view of the prism when Ms. Clinton was wearing it. And then finally, surgery is an option. And I won't get too much involved into surgery because it really is an individual type of procedure. It really depends on how much double the individual has, whether it's horizontal, vertical, or a combination. The muscles are basically realigned behind the eyes to straighten the eye. So let's say the eye is turned in this way. This muscle would be tightened, and this muscle would be weakened to allow the eye to go into a more natural position. And this surgery is done under general anesthesia. And this is a wonderful example of a young woman who had myasthenia. You can see how far her eyes were deviated outwards. They were drifting out. She had an exotropia deviation. And after her surgery, she actually looks quite straight, and she was no longer seeing double vision. So definitely that is an option should all else fail. So I think I'm just about over time, and I wanted to leave some time for questions. So I just want to also just sum up by saying, in my treatment of myasthenia, not only do I use the medications I mentioned, the medical devices, and surgery when appropriate, but I also do strongly believe that a lot of the control of myasthenia rests in your choices, your nutrition choices, and your lifestyle choices. So I definitely do advocate for healthy nutrition and making appropriate lifestyle choices to alleviate some of the symptoms and flare-ups of myasthenia. So again, this is a little bit beyond the scope of this talk, but I do want to just add that because in my treatment regimens, it is oftentimes what I do spend a lot of time talking to my patients about. So with that, I will end and open it up to any questions. If you are on social media, I invite you to follow me. I have a Facebook group called Envision Health, and I do talk about a lot of eye-related symptoms and lots of tips on how to deal with those symptoms. I'm also on Instagram and also on YouTube. And if you would like a copy of my slides, I'd be happy to have my office send you a PDF of them. Or if you have any questions, you feel free to email me. This is my email right here, info@rudranibanikmd.com, which is my website. And I'd be happy to open it up at this point for any questions. So thank you so much.
Thank you so much, Dr. Banik. That was a great talk. We have quite a few questions. I'm going to ask you a few. So one of our attendees is asking, I was diagnosed with ocular MG, and three years later, I had a crisis of not being able to swallow or talk. Am I now considered to have generalized myasthenia gravis?
Yes, so unfortunately, I can't give out personal medical advice or make a diagnosis through this event, this conference. However, if there are symptoms beyond the eyes, then yes, one should definitely be evaluated for generalized myasthenia gravis, and definitely talk to your doctor about the appropriate treatments for you. As I mentioned earlier, though, it's really the same disease, just different muscle groups being affected, but it really is the same disease. And many of the treatments are also very, very similar for ocular and general myasthenia gravis.
Great, thank you. Can a delay in treatment for diplopia due to MG result in a fixed eye deviation that does not respond well to treatment?
Wonderful question. So that brings up the importance of early diagnosis and treatment. So the sooner one is diagnosed and treated, really the better in myasthenia, because as I had shown you in some of the diagrams, with chronic myasthenia, there is an inflammatory response that can ultimately destroy the muscle, the end plate of the muscle. So instead of having those nice hills and valleys, eventually it may become flattened out and just be a plateau. And once that happens, unfortunately, that change is irreversible. And yes, it is with chronic ocular myasthenia, if it goes untreated, it is possible that the strabismus or the deviation will become permanent because those muscle end plate receptors have been permanently changed in their anatomy. So it is possible, unfortunately.
Thank you. The next question is, what antibodies are confirmed with ocular MG?
The most common antibody is the binding, so acetylcholine receptor binding antibody. That is usually positive, however, in only about 50% of ocular myasthenics. So what I mean by that is that 50% of people with myasthenia may have a negative antibody test. It's really very important to point that out. And in that case, we go further with the testing. We do additional testing, like, for example, either pharmacologic testing or the single fiber EMG I had mentioned. The other two antibodies, acetylcholine receptor blocking and modulating, I personally have found that sometimes in some of my myasthenics, the binding is negative, but they may have positive blocking or modulating. And so that's why I order all three in that panel. I know that there are some colleagues of mine who only order one of those three, but I always like to get all three just to get a complete picture. In case one happens to be negative, perhaps one of the other two will be positive.
Great, thank you. Maybe in a percentage, how many of your ocular patients do end up with generalized myasthenia?
This is a really interesting question. So the studies really have not been done in terms of, large scale studies following the natural history of ocular myasthenia. We do believe, though, that if someone has ocular myasthenia and they are appropriately treated within the first 2 years, and the study that I'm referring to used prednisone as treatment. So when patients were treated for ocular myasthenia within the first 2 years of presentation with prednisone, they had a much less risk of developing generalized myasthenia. So that's typically what we tell our patients, but in terms of specific numbers and statistics, we don't have that available.
Great, thank you. So this is going to be our last question, and actually our next talk is about IVIG and immunoglobulin. So this is the perfect question to end with. Is it common to use IVIG for ocular myasthenia? Is this reserved as third line?
It really depends on your doctor's preferences. I myself very rarely use IVIG unless someone has failed the medications. Again, first mestinon, prednisone, and then perhaps some of the steroid-sparing agents I mentioned earlier, like Imuran or Cytoxan or Cellcept, methotrexate, and also rituximab, which is the biologic infusion given every 6 months. At that point, then I would consider IVIG. However, I do know that some of my colleagues who are also neuro-ophthalmologists, they use IVIG much more readily, or I should say much more quickly in the course of the patient's journey with myasthenia gravis. So I really think it's an individual preference based on the practitioner, and just have a discussion again with your doctor about what treatment do you think is best for you. One other thing I will just add to that is that usually I tell my patients, you may not respond immediately, but give it several months to see if there's a response. And I usually recommend at least 3 months on a therapy before determining whether it's effective or not. And, don't just try it for 2 or 3 weeks and say, oh, it didn't work for me, so I need to move on to the next drug or next treatment strategy. Give it a little bit more time before moving on to the next treatment.
All right. Thank you so much, Dr. Banik. We appreciate your time today. And the talk was
Thank
great.
you. It was a pleasure.
Pleasure too. Thank you.
Thank you.
Hi, my name is Dova Levin, and I am the National Senior Director for Program Management and Education at the MGFA. It is my pleasure today to introduce Luba Sobolevsky. Luba is the founding executive director of the Immunoglobulin National Society, or IGNS, which is the central organization in the field of IG therapy. The mission of IGNS is to develop and sustain evidence-based IG therapy standards of practice and professional certification for those working in the field. Luba will be telling us more about IGNS and why what they do is so important for patients. Thank you, Luba, for joining us today.
Good afternoon, everybody, and thank you so much, Dova, for that great introduction. It is my pleasure to be here today, and thank you to the MGFA for inviting me to represent the Immunoglobulin National Society and introduce you to what our organization does. You should know that IGNS and MGFA work very closely together, and we collaborate on a few programs such as this one, and work together really to improve access and education to immunoglobulin therapy and all other treatment options. So it's my pleasure to be with you, and I hope you enjoy this talk. So to get started, I want to talk a little bit about who we are as an organization for those of you who may have not heard about IGNS. So Immunoglobulin National Society is the only healthcare association that is dedicated to advancing the field and the practice of IG, or immunoglobulin therapy. We have programs and resources for clinicians and for patients, and our focus is on education, it's on resources, and for clinicians on certification and standards of practice. For patients, we have a Patient 360 conference. We'll talk about it a little bit later in the talk. We spend a bit of our time on dedicating ourselves and our resources to advocacy, to patient resources, to education, and to learning about the patient's experience on IG therapy and in general with their disease states. And publish that data and make it publicly available for manufacturers, for clinicians, for academic centers who are interested in learning more about how patients do on this therapy. And so I want to start with really, I'm hoping to make you understand why some IGNS and our standards are so important, right? The point of the talk is, what is IGNS and what kind of resources do we bring, and why is this important to you, the patients? So first off, complex therapies, and I think in this virtual room, all of you are receiving one type or multiple types of complex therapies, right? We're not talking about just antibiotics or antivirals. We're talking about agents that change the course of your disease state. Complex therapies really do require specialized education, training, and commitment. As you know, physicians become highly specialized. just like the previous speaker, who was an expert in neuro-ophthalmology. And so you can't really find a medical specialty where someone isn't highly specialized. IG therapy requires highly specialized education and years of training from not only physicians, but nurses who spend the majority of their time with patients during infusions, and pharmacists who manage their care and the product choice and dispensing and so forth. So IG therapy is used in over 70 different clinical indications, which is astounding for any one therapeutic area. There are multiple brands, as you know, of IVIG and subcutaneous IG, and no two products are the same. There are multiple complexities in management of the patient risk factors of individualized product and route of administration. We'll talk about that, and site of care. Then there's the patient and healthcare team relationship that is also complex. You probably all have multiple clinicians, physicians who you see. There are nurses and pharmacists involved, and it is very important for all of these groups to be communicating with each other to deliver the best care for you. And finally, access to therapy, meaning your ability to receive this therapy and your ability to stay on therapy, or what we call adherence to therapy, are also very important. So especially in fields like myasthenia gravis, in other autoimmune neuromuscular disorders, in primary immune deficiency, these are some of the areas that IG therapy is used in. Those complex therapies really require specialized training and education and support for your clinicians. Do you know whether your healthcare team is IG certified? Nurses and pharmacists can become, and there are hundreds and hundreds of nurses and pharmacists who are certified by GNS in immunoglobulin therapy. Next time you talk to your nurse or pharmacist, ask them whether they are certified. And that means, if they're certified, that means they have specialized clinical expertise required for IG therapy administration and management. It brings you peace of mind because these clinicians have had to document their experience, had to pass a very difficult test. They have to meet mandatory recertification requirements every 3 years. And they have to complete a lot of education specialized in immunoglobulin therapy every 3 years to continue to have their credential. And so this is one way where we can both assess a clinician's skills and also let the patients know, right? Communicate to the public, to the patients, what that expertise is. You can actually go to ignurse.com. This is the website that IGNS developed for you to check where you're receiving IG therapy has nurses who are certified in immunoglobulin on staff. Now, you can't look up a particular nurse, so we don't disclose nurses' names. But what you can do is put in your zip code and you will get a listing of IG therapy providers. So that could be specialty pharmacy or infusion center, or even a private clinic, a private doctor's office that staffs nurses, and you can check whether they have IG nurses on staff. So it's a really nice tool to be able to look by geography where those clinicians work. So Dova asked me to speak about the standards of practice and really try to explain what that means to you. Why are the standards important to you as a patient? So as I mentioned, every major clinical and medical field is highly specialized, and it's guided by standards of practice. There are standards of practice for pretty much every disease state that you can think of. The standards protect patients. They ensure patients get the highest quality care every time. And they guide clinical practice. They also protect the clinician and the patient. It's called being legally defensible. And so that happens in every major medical field. Because immunoglobulin is used in so many different indications, IGNS is the first and only organization to establish the IG therapy standards of practice that talk about immunoglobulin as a whole, and we do talk about specifically its use in every disorder or a group of disorders as needed. These standards have now been adopted nationally by pharmacies and infusion centers and hospitals, and they do cover all areas of IG therapy practice, regardless of what site of care, whether it's in a home or in the hospital or an infusion, and regardless of diagnosis. And so it's a very strong document and a very strong standard that really guides our immunoglobulin therapy practice. So why is this important to you again? I'd like you to look at the next several bullets and see if you connect to any of these questions. One of the reasons the standards exist is because in practice, we see a lot of concerns, and we want to make sure that clinicians have a resource to address these concerns so that we can keep our patients safe and we have the best clinical practice every time. And so if you're receiving IG therapy at home, has your nurse ever left you during your infusion? Now, I know we can't do a show of hands, so we're a little bit limited with being in a virtual environment, but think with me and raise your hand virtually if that's happened to you. Does your pharmacy follow up with you, or whoever provides your IG therapy, do they follow up with you after every infusion about any side effects you might be having? How often does your nurse check your vital signs like blood pressure, temperature, or pulse during your infusion? Are your side effects well managed? This is a favorite of mine because so often I talk to patients who say that they have these debilitating side effects, but that they were told it's part of the deal with immunoglobulin therapy. And that's just not true. We'll talk about some of these issues a little bit later in the presentation, but I want to assure you that there are many, many ways to mitigate or lessen the severity of your side effects and make sure your treatments are very well tolerated. And that really adds to not only your success on therapy, your desire to stay on IG therapy, but also obviously the quality of life and your overall well-being. Have you been asked to remove your IV line yourself? This actually happens in practice, and it is absolutely not appropriate. And has your nurse ever increased your infusion rate to just finish the infusion sooner because they had to be somewhere else? And we know we have a huge understaffing issue with nurses, and they have a lot on their plate, but no one should be increasing your infusion rate just to finish sooner, regardless of how you feel. If you're tolerating that, that's great. But are we doing this for the right reasons in an appropriate way? And again, have you inquired if your nurse or pharmacist are IG certified? So if some of these bullets have made you kind of pause or think, and these are just some of the issues that we see. These are some of the concerns that IGNS has always had, and we implement education, resources, and so forth for clinicians to ensure that the patient practice is the safest. And so what's in the standards? What is it? What is it? It's a book. You saw the little image before. The standards is a book that is split into multiple sections. And each section delivers specific guidance to the clinician about what they need to do before, during, and after the infusion. And I think it's really important to you as patients and care partners to understand what is standard of practice, meaning good clinical practice, and if what your experience is very different, then maybe you can have that conversation with your nurse, your pharmacist, and your prescriber, your physician, to ask these questions. And I think the more educated you are as a patient, the more empowered you are, and you can make decisions for your care, and you can change the course of your care and you can make it better. And so in treatment planning, or planning for your treatment, it's not a one-time event. It's not done the first and the only time right before your start of therapy. It is an ongoing plan, and it's a discussion. What is the best route of administration for you? How has your diagnosis changed? What are some of your symptoms? Why are we using IG therapy? We need to have a full medical history, any kind of prior experience on different brands. And we need to develop, as clinicians, an education plan for you as a patient and for your care partner. That is critical. So our patients need to be partners in care, and they need to be part of the decision-making process and that interaction with the clinicians. And what is the desired outcome? It's not just treating the diagnosis. It goes much more deeply. So IGNS standards requires that patient records and prescribing orders be reviewed. In that, we include specific items that must be addressed, like pre-medication list, hydration, 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 hydration. We can't say it enough. It's one of the simplest ways to decrease the severity of any side effects that you might have with immunoglobulin. We do mean oral hydration, drinking fluids, water, tea. That's the best route. Sometimes patients are given intravenous hydration, but if you can take hydration orally, that's the best. We'll talk about medication profile, any over-the-counter meds and supplements. That's important because that also signals other health issues patients might be experiencing that we didn't know about. And also importance of staying on therapy. I think patients must understand what can happen if they delay their dose, what can happen if the dose interval increases, and make an educated decision with your care team. Risk factors are addressed quite a bit, and among patients who are on IG therapy, there are lots of instances where there are additional health issues and concerns. I think sometimes it's the nature of the diagnosis. Sometimes it's age-related. As we age, we all start having additional health issues at times. And so it's very, very important to keep a very close eye on the types of risk factors patients might have, whether there's an elderly patient, whether there's kidney issues, infection, or any kind of cardiac or pulmonary issues. These can all impact IG therapy care. And so the answer is, so what? So we obtain this information about, let's say, kidney or pulmonary issues or heart issues. Well, those additional comorbidities, as we call them, so other illnesses that are on board at a patient, can really impact how well tolerated immunoglobulin is and how safe it is to administer it. And there are some very straightforward ways to address these risk factors by minimizing the rate and the dose. Sometimes we have to split the dose into multiple days. Lower the rate of infusion. That includes patients who are receiving IG therapy for the first time, called naive patients. Anytime we switch a product, a different brand, so brand to brand switches require us to go back to the minimum rate and go as slow as possible. And if it's been more than 8 weeks since your last dose, it is also advised to lower the infusion rate as if you've never received IG therapy before. And so there's lots of nuances in IG therapy administration and safety that we really must be very concerned with and have a very close observation on the patient. IG therapy in itself carries a risk of thrombotic events. Those are clots. So thrombotic events might include deep vein thrombosis, DVT. It might include stroke or heart attack. Now, it is most commonly seen and observed in patients who are of advanced age, with patients who are obese, especially patients who have history of thrombotic events, heart attacks, and stroke, and lots of other risk factors listed here. And what we do for those patients is also mitigate the risk by infusion rate, dose, route of administration sometimes. And so we do have an arsenal of tools that we can use to still safely administer this therapy to patients, even with risk factors. What else is in the standards? We talk a lot about storage of IG therapy. And I know it seems so simple. You all know how to store it. You're given those instructions by your provider. However, there are nuances. There are areas in the refrigerator where if your food freezes or tends to frost over, that is not where you want to keep your immunoglobulin. Or the refrigerator door where the temperature is a little bit higher may not be the correct place to store IG. And these little issues can lead to a vast improvement in care and also access to therapy, because if your product froze, then it's not usable anymore. And it's a very expensive therapy, and we certainly don't want to waste it. So there's a lot of patient teaching, especially in the beginning, that goes into IG therapy administration. And all of that is covered in the standards. And we provide advice on exactly what the clinician should train the patient on when they're starting on therapy and when they're touching base, because we all tend to forget things sometimes, and it's great to come back and be reminded of some of these clinical pearls. Obviously, anaphylaxis and allergic reactions are always on our mind. They're exceedingly rare with immunoglobulin, but there are definite standards in place for management of allergic and anaphylactic reactions. We've talked about the infusion rate. The evaluation before, during, and after is really important. We need to know if the patient's hydrated. Does the patient have a fever? If a patient has a fever and has an active infection, sometimes that increases the rate of how fast your body will eliminate IG therapy out of your system. It's called catabolism rate, and that happens with every medication. But with IG therapy, it may be necessary to hold the infusion for a few days until the fever subsides. All things that need to be addressed by your clinician. Now, management of adverse events or adverse reactions, also known as side effects. This is a big one in immunoglobulin therapy. We know some patients have headaches and chills and fever and fatigue and changes in their blood pressure. And all of those are considered expected side effects to IG therapy, meaning they're not out of the ordinary. And we know that a large number of patients might have these side effects. Can we help the patient tolerate this therapy better? Absolutely. Absolutely. There are lots of ways to do that. Hydration. We talked about that. Slowing down the infusion rate, dividing the dose over multiple days, temporarily discontinuing the infusion and restarting when the patient feels better. And these are just some. There are times when a patient just doesn't tolerate a particular brand of therapy. While all the therapy brands are equally effective in treatments of a variety of disorders, the side effect profile will be different patient to patient. So you and I might have the same diagnosis and tolerate the same brand quite differently. It might work beautifully for you, and I might have debilitating headaches from it. And so I might be a candidate to switch brands of IG therapy to find another brand that is right for me. But that needs to happen after other strategies have failed, such as really taking a good look at the infusion rate, at the hydration status, and any pre-medication a patient might need to help mitigate those side effects. And so there's also a lot of information about both the IVIG route and the subcutaneous or SCIG route. We don't need to get into too much detail. There's obviously a lot of information in the standards. And finally, care coordination. And there's a reason why care coordination is part of the IGNS standards, and it always has been. We know our patients are seen and treated by a variety of specialists. I know you all have more than one doctor that you see. There are multiple nurses and pharmacies and pharmacists that you are in touch with who support and deliver your care. And the patient and clinical team must coordinate in order to achieve the best treatment outcomes. So we want the patient to voice their goals for their health. We want the patients to let us know the comfort level with the process that was selected, with the product, your capabilities. Are there any barriers to adherence to therapy? Are there barriers to staying on therapy? Is your infusion center too far? Or is your home just not suitable for infusion at home? Are there any other barriers? And then any changes from the start of treatment, from baseline. Are you getting better? Are you getting worse? Are you staying the same? And how do we know, right? And so the patients really need to be part of this team. And pharmacy, nurse, prescriber, and advocacy groups like MGFA are really form this sort of cloud of support, and there needs to be collaboration and communication. And so in the IGNS standards and a lot of our other resources in education, we address those issues and we teach clinicians how to form these teams. And conversely, in our patient programs, we really provide a lot of education to patients on how to be a very strong advocate for yourself, for your health, and how to have a voice that your healthcare team actually listens. And so with that, I'll segue into a little bit of information about our Patient 360 conference. And Dova and MGFA have attended this conference many times. This is going to be our 6th National Patient 360. It is a 2-day conference for patients on immunoglobulin therapy. All diagnoses, regardless of where you receive your IG therapy. And it's a fantastic way to learn about IG in your disease state, in other disease states, how it's different, how it's similar. We have tons of breakouts with clinical experts. We have a lot of sessions that go beyond your diagnosis, and we talk about your quality of life, long-term planning, advocacy. We have talks, we have several sessions about long COVID this year. So a lot of really good quality topics that also help you see what other patients with other disease states on IG therapy experience and how we can all learn and improve our practice. This is completely free to all patients. It's completely free to your care partners and families. And I invite you to join us in May. The information is right there. You can just scan that QR code or get in touch with me after this talk, and I'll be happy to forward you some information. So we hope you also attend Patient 360 and be part of the IGNS community. And finally, for any of you who are clinicians in this meeting right now, our national conference, IGNS 2022, is back. It's live in Washington, D.C., September 29th through October 2nd. And you can also take a look online and see our full agenda and all the meeting details. We're very excited to have these 2 conferences back this year, and really looking forward to working with all of you and hopefully seeing all of you virtually and in person, I hope soon. With that, I will stop in the interest of time and take any of your questions.
Thank you, Luba. We do have a lot of questions coming in, so we'll try to get to some of them, and then we're going to have a short break. So there's a couple of questions about the different brands I'm going to summarize a few different questions together, but
Sure.
people are asking, they understand that different brands have different side effects. Different brands of IVIG have different side effects. They're asking why this is. Like, is there a reason for that?
It's a really great question. And I just put our email address into the Q&A chat, mine and our association, in case we don't get to those questions. Feel free to drop me a line. We have some idea, but really no one's been able to pinpoint the exact mechanism of why each brand has a very different tolerability profile. Each brand does contain the same concentration of immunoglobulin, IgG. And so there are very stringent requirements of the percent of IgG versus other formulation additives there has to be. So we're all guided by the same industry and regulatory standards. They all go through the same safety steps. Some are proprietary different, some are similar to prevent any kind of infectious disease transmission. So the efficacy and safety are equivalent. Now, tolerability or side effect profile is different. And it's not just the product, it's also the patient. And so every formulation is different. While IgG is the same, there are other things added to the solution to stabilize it and to have a longer shelf life. And so these minor differences in the formulation is what seems to have the biggest impact on how well tolerated a brand is. But again, if you gave the same brand of therapy to Dova and I and let us have that infusion, we might have a completely different reaction. And it doesn't mean there's anything wrong with the product. It is how your individual response is. Why that is, why that has that response in the body, we don't know. But the differences lie in the formulation of each of the IG therapy brands.
Thank you. The next question is, could you address how important it is to consider rate of speed for the infusion as a way to manage side effects, particularly with regard to doctors being sensitive to that speed?
Yes. So infusion rate is extremely, extremely important. If you think about what immunoglobulin is, right, it is an immune product, right? It contains immunoglobulin, which your body has as well. And so when you receive IgG, especially intravenously, there is a certain amount of that Ig protein that is going into your bloodstream per minute, let's say. And it triggers an immunological response right away in your body. And so the faster we infuse and the more IgG or the more this protein per unit time, whether it's a minute or per second or per hour, the more of it reaches your bloodstream, the more likely it might be to cause side effects. And we know for a fact that if we scale back the infusion rate to the slowest possible, and IGNS standards say start out at the slowest infusion rate that a patient can tolerate and increase it in no fewer than 3 escalation steps. So if you're going to start at 0 and you're going to go to whatever your max infusion rate is, our standards say that you need to increase that in 3 steps, checking the patient's vital signs after each rate hike. And so that is done to protect the patient's tolerability. And if there are side effects, then we need to slow it back down to the previous step or stop and then restart again. And so we have a lot of guidance surrounding this particular area, because this is where a lot of the side effects come from.
Do you know if emergency departments have certified IG nurses in case of an MG crisis?
You know, it really depends on the hospital and the emergency department. I suspect that very few are IG certified, because emergency department physicians, nurses, and pharmacists have to be trained across multiple areas, right, to be able to address. I mean, they're getting things, anything from abrasions to gunshot wounds to people who are having a crisis of their chronic illness. And so I wouldn't suspect that those particular clinicians would be highly trained in any particular area of practice other than emergency medicine.
Sure. We have time for one more question, and this question is: a patient got pretty bad side effects from her infusion, and she's asking, should I try another brand? And so that I'm assuming that, listening to your talk today, that's a good idea to possibly try something different.
So I would say that, I mean, it is difficult to answer that question, obviously, because I don't know anything about your history and how long you've been on this brand. I would say if you've only tried one brand once, then we need to really understand what other factors there are. Was the product cold? I mean, there are times when even the clinical team doesn't know that the product has to come to room temperature before infusing, which means 2 hours on just a room temperature surface, not in a hot bath or anything like that. But cold IG, too fast of a rate, hydration status, were you well hydrated? There are many, many, many of these factors to consider before saying, you know what, this product is not something I can tolerate, I need to switch. Now, if you've gone through all the iterations and you've addressed all of these issues, and the rate is low and you're splitting your doses and you're very, very well hydrated and you're pre-medicated and all of these factors have checked off and you're still having tolerability issues, then yes, I would say that is definitely a valid reason to try a different product and see if that works. Definitely.
Well, thank you very much. We will be posting the information about the IGNS conferences on our website. So while we can give you Luba's information, we'll also have it at the MGFA website as well. So Luba, thank you very much. A pleasure that you joined us today.
It was my pleasure. Thank you.
Thank you.
Have a great day, everybody.
All right, we're going to take a short break now. Thanks, everyone.